Assalamu alaikum, the long clinical consultation day. The first scenario, Mr. John Smith, 35 years old, with a complaint of dizziness. Please see the patient and examine him, address his concerns.
Okay, hello.
Hi, doctor.
I'm Dr. Akbar. I'm one of the doctors in the clinic today. May I confirm that you are Mr. John Smith, 35 years old?
Yes, doctor.
I'm here to discuss regarding your health condition. For that, I'll be taking your history and doing your examination. Is it fine with you?
Okay, doctor.
So, can you tell me that what has brought you in the clinic today?
Actually, is this dizziness, doctor? I usually feel as if I'm about to fall, and I'm so worried about it, doctor.
Okay, so Mr. John, may I know that is it the first time you are experiencing this dizziness or something
No,
similar happened
no,
in the past?
no, not at all, doctor. It has been on and off for the past um 3 months
Mhm.
now, doctor.
Okay, and during these disease spells, did you lose your consciousness anytime?
Just once, doctor.
Just
Yeah,
okay.
just once.
And this episode is just similar like the past one or something different from the past?
Yes, it's similar, doctor. Similar.
Okay. Did you hurt yourself during this time?
Not at all. I was just, relaxing. I just came back from a football match. I was just relaxing, and before I know it, I was feeling dizzy. And
Okay.
then suddenly, they have to take me, wheel me down here. And then the doctor in the emergency gave me some injection. Now I'm kind of better, but I still feel a slight
Okay.
of dizziness. Yeah.
Okay. May I know that before the dizziness, like what were you doing?
I was this particular one. I just came back from a football match, you know.
Mm-hmm.
Yeah, so I was
So,
feeling tired, so I just relaxed and I started
okay.
feeling dizzy.
And okay. And like, is it this your usual routine or did you play it more at that day?
Actually, I really played much that day,
Okay.
basically.
Were you hydrated? Were you hydrated that day?
Yeah, I think I drank a lot of water. I did, drank a lot of water. Yeah,
Okay. Okay. And did you felt that the weather was quite hot that day or it was fine?
no, it was fine. Not at all. It was fine. It was
Okay.
fine, doctor.
Did you feel any racing and pacing of your heart before the dizziness?
Yes, I did. I did, doctor. Yeah.
Okay. And was it very fast? Did you like if I ask you to tap, is it fast or regular? Can you tell me?
It's fast, but it's regular, doctor, but it's fast.
Okay.
Yeah.
Okay. Yeah. And did you experience any chest pain with that as well?
Not at all. No, no chest pain, doctor. No,
Okay. All right. Did you had any difficulty in breathing at that time?
no, not at all. No.
Okay. When you had this disease spell, anyone checked your sugar levels at that time?
The last time I had it, when I was rushed to, I collapsed eventually. I went to the hospital and they
Mm-hmm.
gave me something like that was very sticky in the drip,
Okay.
and I was
Okay.
better. Yeah, most likely it was. They said my sugar was low, and they gave me some correction. I was better, so I have to go. I have an appointment to catch. I couldn't wait for the diagnosis to be made.
So every time when you had the dizziness, did you check your sugar levels? Was they low all every time, or it was the only time?
I just noticed that when I feel dizzy, I have to eat something. Once I eat something, I feel a little bit better.
Better.
Yes,
Okay.
yes, doctor.
Okay.
Yeah.
Okay. During this time period, has you noticed any abnormal shakiness in any part of your body?
Yes, yeah, I feel as if my hands are shaking. I feel I'm kind of I want to eat. I feel hunger for food.
Okay.
Whenever I feel this
Okay.
dizzy, yeah, so I have to just eat.
Okay. Were you having any sweatiness?
Yes, I do have sweating. Yeah, I sweat. Yes,
Okay.
doctor. I do.
Sorry to ask you that. Did you soil your pant or wet your pants during this time period?
No, not at all. No, no, no.
Okay. Any headaches?
No, doctor.
Okay. After the recovery, do you feel that you were confused?
Actually, after recovery, I felt better after the because I was kind of dizzy. Anyway, I did this
Mm-hmm.
particular one. I didn't lose consciousness. This particular one, I was just dizzy. But after the injection, I was fine. I was fine.
Okay.
Yeah,
And
yeah.
has anyone noticed the skin color, your skin color changes during this time period, being pale, bluish? Has
No,
anyone
no,
noticed
no,
this?
no, Not at all.
Okay.
Not at all.
So, Mr. John, can you tell me, is there any long-term illnesses you would like to tell me?
Actually, no, well, no, not really, not really, doctor. Except
Oh, okay.
sometimes yeah, not really. Except sometimes I pee a lot, kind of, yeah.
Sorry?
I go to the I pee a lot. I urinate a lot,
Okay.
Yeah,
And for
basically.
how long you are passing this waterworks too much?
But it has been long for the past 2 years. Yeah, no,
Okay.
it has
Did you
been
get
long, a
any?
very long time. Pardon?
Okay, all right. Any history of hospitalization or surgeries?
No, 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 not at all, doctor. No, not at all.
Okay, all right. And any over-the-counter medications, any herbal medications, anything else you have been taking?
And just once in a while, when I have this tummy pain, I just take some painkiller,
Okay,
paracetamol, and not, just once in a while.
okay. Any weight changes during this time period?
Yes, doctor, I've kind of added a little bit anyway. I've kind of because I eat too much, so I feel that I've added. You know.
So you have like weight gain, you have weight
Yes,
gain.
I've been eating. I've been eating a lot. And probably I think I've increased in my weight, doctor.
Okay, and okay,
Mm.
all right. And like, is it like overall weight increase or just your tummy?
No, overall, like I said, I eat too much. In a day I can eat more than 7 times in a day. So
Okay,
I feel as if I've added.
okay,
Mm.
okay. And may I know that is there any lumps and bumps in any part of your body?
No, no, doctor, no.
Okay, are you being tired these days?
Sometimes I feel tired, but not all the time. Just sometimes.
Okay.
Mm.
Any numbness and tingling in any part of your body?
No, no, doctor, no, doctor.
Okay. Any problem in your bowel works being loose or being hard?
Yeah, sometimes, not all the time. I feel as if I take sometimes 4 days for me to go to toilet, but not all the time. Sometimes.
All the time. Do you
Mm.
feel any acid brush?
Acid bash. I just had just one episode, but that was some weeks ago when I was sleeping. But after then, I didn't have any other episode again.
Okay. Any vision problem?
No, no, no. I see very well, doctor.
Okay.
Mm.
Any joint pain?
No joint pain, doctor. No,
Any muscle cramps?
no, no, doctor.
Okay. May I ask you some personal questions?
Okay.
Any similar complaints in the family?
Not at all. My dad died so when I was very young, and my mom told me that he had a brain tumor, and they went for a surgery, and he died doing the surgery.
Okay. Okay.
So,
I'm sorry to hear
mm.
about this. What was the cause of your father's death?
Like I said, I was only a child, so you say he had a brain tumor, so they went to do a surgery for
Okay.
him. Doing the surgery, he died on the operating table.
Okay. And may I
Mm.
know that is there any problem? May I know that do you have a partner?
Yes, I just got married 3 years ago.
Okay. Sorry to ask you,
Mm.
like any problem in the intimacy with the partner?
Yes, actually, my wife has been complaining that I don't usually have zeal for intercourse. I have this problem with my
Okay.
erection.
We
Yeah.
okay, we'll try to help you out in this regard as well.
Okay.
Okay. And may I know that do you smoke?
No, not at all. I tried it
What
once,
about
but I was
alcohol?
not. Occasionally I drink, but not all the time.
Oh, good to know about that you are not smoking. And sorry to ask you any party drugs?
No, no, doctor.
Okay. And may I know that do you drive?
Yes, I do, but not all the time, but I do. Mm.
Okay, so right now we'll hold on your driving as you have been feeling dizzy and you have lost your conscious one. So we'll see that what's happening with you. Is it fine with you, Mr. John?
Well, if you say so, I will think about it. Yeah, I'll try.
Okay. And okay. And may I know that what do you do for a living?
Yeah, I'm a coach. I coach with the under five. In the school. I'm a coach in the community school.
Okay. And how are the symptoms affecting your daily life for this time period, for these 3 months?
Actually, it is because these days I usually go with snacks. To
Hmm.
work to train the boys. I go with snacks and then we drink. So when I start feeling dizziness, I just say I have to take some couple of coke.
Okay, so we'll try to help
Mm.
you out in this regard and we'll see that what's happening. So I would like
Okay.
to examine you, Mr. John.
Okay. Okay. Yes.
Okay, so First, I will start my examination by looking at the patient. I would like to know the BMI of this patient and overall look, like if he's like central obesity, it's like he's overall obese, any features specific in the patient. Then I would like to check the hands of the patient
Yes.
for any hand changes, any nail changes, and then any skin thickening, any pin pricks, also any sweaty palms,
Normal. Yeah, the
and
palms are sweaty, but it's normal.
the hands are of fine. Any shape changes, anything?
No, normal. Normal.
Okay. Okay, all right. I would like to offer for the reverse prayer sign in this patient.
Reverse what?
Uh,
Prayer sign. Prayer sign.
felon,
Yeah, is yeah,
reverse
it's not. It's
felon
normal.
sign, reverse
It's
prayer.
normal. It's normal. Normal. No,
Okay,
no. Yeah,
okay. I would
negative.
like to. Oh, okay. I would like to check the face of the patient, the eyes. Any
Yeah, the face
problem
is
in the
good,
visual acuity?
and
Visual
the visual
acuity.
acuity is good. Good.
Okay, okay. I would like to check for the 3, 4, 6. He can see any doubles or anything.
Normal.
Okay, I would like to offer for the fundoscope at this point.
Okay. Fundoscopy. Normal.
Okay, all right. Then I would like to check the mouth in the patient for any signs of pigmentation and dehydration, any anemia, jaundice. I would like to check the lymph nodes in the neck,
Normal.
any neck
Normal.
swelling.
Normal.
Okay, okay. I would like to check the back of the neck as well for any skin darkening, any skin thickening. Also the abdomen for any stria, any skin thickening, any skin changes. I would
Normal.
like to check the Okay. I would like to check the legs of this patient for any skin changes, for any edemas, any
Normal.
feet changes. Okay.
Normal.
I would like to offer for the proximal myopathy, urine dip.
Normal.
Okay. And then in the end, I would like to offer for the bedside sugar level, sugar RBS in the patient.
Okay. Okay.
Okay. So, Mr. Joan, what are your concerns, please?
Yes, doctor. What do I have, doctor?
Mr. John, after taking your history and doing your examination, there are a few possibilities. And I believe that you have a condition called insulinoma. It's a condition when there is a gland in our tummy secretes a protein in excess, and you can have these episodes of low sugars, and you can have the similar symptoms you are experiencing right now. But we have to do some blood test, some scans of your tummy, and other tests so that we can discuss further management plan with you. Is it fine with
Oh,
you?
yes. Thank you, doctor. It is. It's fine with me.
Okay,
2 minutes
so we
left.
will. Okay, so Mr. John, we will be making a team of doctors. It will include a gland doctor, a physician, specialized nurses. We'll do some baseline test, some scans of your tummy as well. We'll do some test of your waterworks as well if required, and we'll discuss that how we'll manage your plan and do the further management. Is it fine with you?
Yes. Thank you, doctor. Thank you, doctor.
Okay, any other concerns for me?
Yes, doctor. Is is it a cancer? This condition you mentioned?
So, Mr. John, I appreciate your concern. Cancer seems to be unlikely, but we'll keep this in mind when you are doing the blood test and scans. So, we'll update you.
Oh, okay. Okay, doctor. Doctor, I don't know. Peradventure, I start having children. Will my children have similar condition?
This condition, uh, it's not likely that they can have this condition as this does not run in the family. But as you have having the condition, so the chances are higher from the normal population that have it. But that's not something that runs in the family.
Oh, okay. Thank you, doctor.
You're welcome.
Still 30 seconds. You want to examine anything else? You want to ask
Okay, I
about
will.
history?
any other medications, or he would like to show me, and I would like to offer for the postural drop as well in the patient if it's there, if I have time.
Okay. 6-5.
For
Okay, time is up. Examine your question, Dr. Hillary.
Can you present your patient? Positive findings.
so I have examined this young male with a history of dizziness for last 3 months, and which is usually seems to be without any loss of consciousness. One episode of loss of consciousness was there when he had some low sugars. The dizziness gets better when he eats. These are recurrent symptoms. He had given an history of weight gain, but that's with increase in the diet as well. Patient history of hyperphagia as well. There is no significant past medical history of note. Other than that, there are significant history of family in with the father had the history of a brain tumor as well. And other than that, he is a gym coach. And on examination, I could uh, there was overall a normal examination, I believe, other than any findings in the examination.
Okay. What's your differential diagnosis?
So I would like to keep insulinoma as my first differential in this case. I would like to keep Addison's as well in this case, Addison's disease. But other than that, patient has history of weight gain and increased appetite, which go against that. Um, Other than that, I would like to keep man 1 as my differential as well in this case. But I could not find any other features of acromegaly and hyperparathyroidism in this patient. So I would like to keep as differential as well. And other than that, that's it. These are my differential.
Okay. All right. How will you investigate this patient?
So I would like to go for investigations in form of complete blood count, kidney function test in this patient as well. I would like to go for an serum insulin levels, serum C peptide levels in this patient, HbA1c in this patient as well. I would like to go for serum insulin levels as well, and I would like to go for an ultrasound whole abdomen in this patient as well. Uh, Other than that, urine routine examination, and for other differential, I would like to go for short synaptic test for Addison's and thyroid profile in this patient as well. And I would like to um, that's it. And management will be in form of education, counseling, explanation, making a multidisciplinary team, which will include an endocrinologist, physician, specialized nurses. I would like to treat the patient like I would like to the medical treatment will be in form of somatostatin analogs, could be in form of octreotide, and the definitive treatment will be surgical intervention in this patient if required, dietary modification, lifestyle modifications, and then treating the other cause if there is underlying other pathologies.
All right. Thank you so much. Thank you, Dr. Akbar. That's a
Thank you.
good presentation. Your fluency was good. Your
Dr.
issue
Henry,
was
still there is 1 minute, 15
1 minute.
seconds.
Oh, sorry. Okay.
Yeah, you can add some questions.
Okay. Okay. Sorry, Dr.
No
Badu.
worry.
Um, assuming
Hello.
this patient. Okay. Hello. Okay.
Yes, please.
How will you differentiate between a patient that takes exogenous insulin from a patient with insulinoma presenting to the hospital? How will you differentiate the two of them?
So I would like to go for if the patient is taking any over-the-counter medications, specifically any insulin or any other hypoglycemics. I would like to compare the proinsulin levels with the C-peptide levels and with the urine insulin levels as well, with comparison with the serum C-peptide levels.
Okay. So what will you see? What will you see that what will differentiate the two of them?
So, in insulinoma, there will be serum rise in the insulin levels, but the urine levels would not be higher, I believe.
What else?
That what I know only.
Okay, thank you. Dr. Bazim, can
Yeah,
I?
okay, time is up. Yes, you can comment now.
Right, like I said, you did very well. I must commend you did very well. But actually, your history was, I was giving you some clue, but because typically the gut issue, the patient has insulinoma, quite all right. But he also has some other things outside the insulinoma. The patient has
Mm-hmm.
MEN1, he has
Mm-hmm.
features of hyperparathyroidism, which is features of hypercalcemia, but you didn't really go through, you didn't get the history very well. This patient has
Uh,
constipation that comes, occasionally. It tells you that it takes time up to
uh,
4 days for him to go to toilet. These patients sometimes take painkillers for abdominal pain, likely flank pain, which may be due to, you know, renal stone. You didn't dive deep into that history. You know, this patient, like you said, has polyuria, he has polydipsia, but he didn't further ask, you know, that history to get the history of polyuria, polydipsia, which is in keeping with the hypercalcemia that he has. As when you got this history with the polyuria, polydipsia, and the flank pain, which is issue of recurrent renal calculi that he said that he has been taking painkillers for those pain in the tummy, you know, you should have probably tied up with and then he has erectile dysfunction. It tells you that he got married 3 years ago, and yet he doesn't really perform very well. He doesn't have the urge to have sex with his husband. You know, he did ask about milk discharge. Sometimes they may not come down with macroadenoma. They may just have micro in some of them, like in this patient, is a male patient. The vision symptoms, which is the feature of macro, which is MA, is not really seen in this patient. What he has is just the micro and it's functional. So he has evidence of erectile dysfunction. You still have some nipple discharge. You didn't ask to get, an issue of galacturia. You did not ask. So all these are in keeping with the pituitary adenoma, but in this case, it's more like a microadenoma that he has. That's why the issue of headache, blood innovation is not seen in him. But he has erectile dysfunction. He has what do you call it, nipple discharge. He has the breast is a little bit of, if you examine the breast, you should have examined the chest, examine the breast on the, that is for that. Then, and also when you look at the family history, yes, he had the family history of the dad has a brain tumor, which likely to be maybe a pituitary tumor that he went for the surgery but died during the operating table, most likely. So once you get a history of a brain tumor, or probably a history of one of them, one of the three P's is one of the criteria, and the patient is now presenting with evidence of hyperparathyroidism, evidence of insulinoma, and the evidence of pituitary adenoma. So with these two, you can be able to back up your plan that this patient most likely is having multiple endocrine neoplasia type 1. I think that is where if not, you did very well, but you didn't really get the history. Your issue was not very detailed to rule out completely the issue of hyperparathyroidism and also pituitary adenoma. By and large, your examination too was okay. At least you got the sweaty palm and everything, but you should examine the breast and see if there's any, breast swelling, check for the genitals, and then see these are some, or ask to check for the ask, not really, but you can just ask and see if there's any, thing there. And then basically you try to rule out the macroadenoma by checking the HSI. You did that, which is a good one. So basically Your differentials were okay. You mentioned also you mentioned the men too as a differential diagnosis, which is good. But what the patient has is men. And when the patient asks about the issue of when I ask you about the issue of if my children we have it, yeah, I don't know your the response you gave. What was the response you gave?
Sorry.
When I asked about if my children we have similar condition, what was the response?
And if I keep man one in my mind, so obviously there are chances that
Yes,
your children can have it. If I think about man one, but
yeah,
if I think about only insulinoma, then individual entity, so I can think that way. But as a man one, obviously I'll tell that there are chances. We'll
okay,
do genetic test and other gene analysis.
lovely. So I think Dr. Bazim, these are just my only addition to add. If not, she did very well. Just that she didn't get that complete history to rule out the hyperparathyroidism and the
Yes,
pituitary adenoma. Basically, thank you very
perfect.
much, Dr.
Yeah,
Agba.
thank you.
Thank you.
Thank you.
Mm.
Thank you, Dr. Hinari. Well done as a comment and as a case. I will comment now, Dr. Minam.
Yes,
What
sir.
you have missed in the history, it, it put you in a trap. The only thing you jump or you skip is the system review, right? Agree for that.
Uh, Sir, for prolactinoma,
Leave
I
leave
just
the
missed.
prolactinoma. I will tell you, even if you miss the prolactinoma while taking history, you didn't ask about the
Hmm.
bowel habit, right?
Sir, I asked for any loose or tight, but I think it was just missed or something like that.
No,
So
I
I
think
couldn't not.
I think you didn't ask. Did you ask? Did she ask Dr. Henry? I'm not sure. Because if he
I
tell you
I
heart,
didn't get it. I didn't get it
yeah,
from
I
her.
think so. I think so.
I
I remember when you reach to the difficulty of swallowing, you skip to the family history. You didn't ask about the water work, the polyuria, I mean. And so he can give
I
you the polyuria.
I asked her for waterworks and bowel works. Maybe couldn't hear, but
She
I have
asked.
written. I
Yeah,
have asked.
I
Yeah, I
remember
asked.
she asked about bowel
I
habit.
asked. Yes, sir. But I said there's some net problem maybe, so it missed. I think
What was my response when she asked? What was my
maybe.
response?
It's okay. It's okay.
What was my response, Dr. Agba, when you asked? What did I say?
Uh, I don't remember actually, but I asked. Maybe it was not.
No,
I couldn't hear,
you know,
but
you asked of my bowel habit, and I said I have constipation. Sometimes it takes me up to 4 days for me to go to the toilet. I said that when you asked of the bowel habit, but you didn't ask of the water
hmm.
works. You didn't ask of water
Yeah,
works.
I remember the water work when she
Mm,
asked about she feel there is hyperglycemia, and he
yes,
told you that he feel polyphagia or
That
polyphagia.
yes.
Yes,
Yeah, I
he's
mentioned
eating
it.
yeah,
too much. Okay,
Mm,
too much
maybe
fury.
you were
Hmm.
preoccupied with the insulinoma. That's why you ignore the other manifestation or the other association.
Hmm.
Be sure,
Yes, sir.
be sure. If the case is straightforward and you
Hmm.
have isolated, okay, isolated disease or something to be alone, and usually it might appear as syndrome like men,
Hmm.
be sure there is a trick in this scenario. So don't miss it. What you have to do to screen for the others. Particularly here, yes, you catch which is called is insuloma. However, you miss the pituitary. And by the way, the family history or the father will not, he will have a condition that's run in family, and the only
Hmm.
condition with gland which runs in the family is the men, or polyglandular syndrome, polyglandular syndrome,
Hmm.
or men type 1 or type 2. Whenever the insulinoma comes in paces, be sure there is a twisted scenario. You have to screen for other men, including pituitary and parathyroid. Even the patient will feel polyuric. It might be related to the hyperparathyroidism. The patient might be also having depression. So you have to ask about the mood, which you miss here also, one of the question. The constipation also one of the question. Passing renal stone or gravels or even passing a lot of urine. It's also one of the manifestation and question you should ask. So it's a matter of combination. If you put in your mind that I can have this disease, you will ask it. Maybe because you preoccupied with the insulinoma, you didn't go to the questions of main one. Anyway, I always saying you are learning from the mistakes more than when you do a perfect case or you do a case without mistakes. Okay, so the insulinoma now or the main one now, you will never miss it. Any case, I believe you ask about the hand size and the leg, the feet size,
Hmm.
but
Joint pain,
still, yeah,
muscle
this is for
cramps, and water
acromegaly.
weight for
Yeah,
yes,
this
sir,
is for acromegaly.
even for
Yes.
gastrinoma, I was trying to rule out for acid brush, joint pain, muscle X
Yes, you
for
ask it.
hypercalcemia.
Yes, you
But
ask
like
it. Yes, you're right.
for gastrinoma, I was trying
Yes.
to rule it out, but maybe
Yeah, it's okay. Maybe
symptom.
miscommunication or you didn't hear it well. Anyway, we are learning again from the mistakes. So the take home message from this scenario, please, whenever you start to screen, ask about all conditions.
Hmm.
Maybe also here you analyze more for the dizziness. I think 5 or 6 minutes you are asking about the dizziness. You have
Hmm.
you have a confirmation or a proof this is a dizziness due to hypoglycemia, right?
Hmm.
Because sweating, palpitation, feeling hungry improved with blood sugar or sweaty food. But I think also you analyze it more and you took longer time to reach what could be the reason. Okay. The other question also was good. Did you hit yourself? Any trauma? Did you wet
Hmm.
yourself? All this question, okay, makes sense. But try to fast finish it because you have a lot of association in this scenario. Okay.
Hmm.
Whenever you are going through the history and you have positive finding, write in your paper what you should examine. Examination, a title of examination down in the paper. Then whatever is positive in the history, you have to do examination for it. What do you think is important to do here as examination? Three system. Give me at least three system.
Hmm.
What do you think?
So, first for the CNS, visual acuity,
Perfect.
346, and visual fields for
Perfect.
bitemporal hemianopia, first, it was ruled
Perfect.
out by
Yeah.
doing the. Then in the hands, same sweaty palms, any pinpricks for insulinoma, for acromegaly, all these things, it was
Okay.
also ruled out. Then for abdomen, for any gastrinoma or Zollinger-Ellison syndrome, like any tummy tenderness or any constipation, any plan, but it's not necessarily present in the patient. And then what I miss is like breast examination for any nipple
Perfect.
discharge
Yeah.
and offering for the genital examination in the male.
Yeah. So the breast is the most
Yeah,
important. Yeah. So
yeah.
any gynecomastia or galactorrhea, so you have to examine or to offer examination for the breast.
Hmm.
Otherwise, you can offer yes urine dipstick and the
Hmm.
feet size if you
Hmm.
suspected acromegaly. These are the and the thyroid, by the way, the thyroid for parathyroid adenoma.
Yes, sir.
Okay.
Hmm. Thyroid.
So these are the component of our men and the examination of each part. Clear?
Yes, sir.
Yeah, it's very high yield topic in the exam, by the way. The men as a manifestation or autoimmune polyglandular syndrome. So you might have
Hmm.
Addison also, along with thyroid and diabetes.
Hmm.
Don't miss it. Okay, if
Hmm.
you have any of them, search for others. Addison can present with dizziness, and you might have
Hmm.
thyroid with it,
Hmm.
and you might
Celiac.
have diabetes with it. Celiac could be also there, and vitiligo as also as any
Hmm.
autoimmune association. Okay.
Hmm.
Okay. Perfect, Dr. Minal. Yeah. Okay. Let's start, Dr. Henry. Your case, 45
Okay.
years old, male. Let's say this is Mr. Jack with arm weakness.
With what?
Arm weakness. Arm.
Arm
His.
weakness.
Yes. Arm
Okay,
weakness.
okay.
Yeah. Take your time, and when you're ready, let's do. Dr. Inas is asking, can I go next, please? What is the differential for men? Men one. Okay. Whenever you have main one as a differential, you can put the component of main one as isolated. So you might have isolated insulinoma and it can cause dizziness. In our scenario, men with insulinoma can also be the reason of dizziness. Or as Dr. Minam said, Addison as hypoglycemia cause and or a dizziness as well. But again, is that no loss of weight or diarrhea, for example. Okay, Dr. Inas. Any question, Dr. Inas, else?
No, thank you.
Okay, you asked for to be the next as a participant, right? Or I
Oh, yes,
misunderstand you?
please.
Yeah, Dr. Inas, our rule on the session, two partners or two participants, they are giving each other a case. This is
Okay.
our,
Oh,
okay.
yeah,
So
that's fine. Sorry, it's my first time to join, so I did not know
it's
the.
okay, Doctor. It's okay. Anyway, you are free. You can feel free to comment, to participate, adding questions or comment, suggestion. Okay.
Cool. Thank you.
Okay. As you talk, let me ask you about, okay, what are the mode of inheritance in men one, and what is the gene?
Oh my God, I don't know. Oh,
Yeah, the
um,
first thing to answer is I don't know, but if you think you might get it, try to get it or to think about it, you might get it. Men one,
um,
the mode
maybe,
of inheritance. What do you
maybe
think? The
in
first,
the case they mentioned the first degree relative having similar kind of
okay,
condition.
yeah,
It could be
so
autosomal dominant.
perfect, that's it. So how much the percentage?
Pardon?
How much the percentage of
Sorry,
inheritance?
I'm sorry, I don't know. Oh,
Any autosomal,
if it is autosomal dominant, so
yeah, yeah,
50% for each child.
exactly. Yes, yeah, that's it. If you think you will answer, by the way, it's a matter of thinking. But the easiest thing to do or to say, I don't know. Just take a breath and try to think. Okay, the second question. What is the gene?
I think it's called Min1,
Wow, oh my God. See? You answer both questions.
but I'm not sure on what chromosome, to be honest.
Yeah, it's main gene. Main
Yeah,
gene.
but on which chromosome, I don't know.
No, no, I ask about the gene only. I didn't ask
Mm.
about chromosome, okay? And what about main 2? What is the gene?
It must be Min2.
No,
Sorry, I don't know.
red, red gene. Red.
Oh, Ret. Oh, yeah, Ret is an oncogene. You're right.
Yeah, red. So you know the answer, but need to think only. Okay. This is
Yes.
our nature. Usually we are saying I don't know or we are avoiding the answer. But if you think you can catch it. Thank you, Dr. Ines.
Thank you.
Again, feel free to comment anytime and whenever you want to participate, message me. Okay?
Thank you.
Most welcome, Dr.
Can I just ask, do you do this every day?
Yes,
And how
every
many
day.
cases do you normally discuss?
It's two cases as two participants. Everyone will give the other as a case of
Okay.
either long clinical or communication, and some weeks we are doing the shorts. So
Oh,
both participants will be sure that they will practice, and we can have a discussion on each case. Okay.
fantastic. Amazing work. Good luck, everyone.
Okay. Thank you, Dr. Nas.
Thank you.
Anyone with question? Thank you. Anyone with question before moving to the next scenario? Okay. So we can move. Dr. Henry, are you ready?
Yes.
Okay. Henry.
Right. Good evening. I'm
Hello.
Dr. Henry, um, one of the doctors here in the clinic. Can I confirm your name and age?
Doctor, my name is Jack,
Jack. Okay. Your age?
and I'm 45 years old.
45 years old. Okay. Mr. Jack, I just go through your notes and I noticed that you are having or you are complaining about a arm weakness. Can you tell me more about this, your complaint?
So, doctor, I had this weakness. It's been here for last one day, and I was watching TV when this happened, and I don't know, my right arm was stopped working suddenly, and since then I'm not able to move it. I'm not able to feel anything.
Oh, so sorry to hear about that. This must be very difficult for you. And don't not to worry, we'll see how we can support you in every step of the way. Is that okay?
Thank you, doctor.
All right. Concerning your arm weakness, you said it's your right arm, right?
Yes, doctor.
And it was sudden when you were watching the television.
Yes.
And it was yesterday. Am I right?
Yes. Yes,
Okay.
doctor.
Around which time yesterday? It was in the morning,
Doc-
afternoon, or night?
doctor, it was around morning, I believe,
So
around 12 p.m.
okay. So it's more than 24 hours, right? Say now.
Yes, sir. It's more. Yes, doctor.
Okay. Is the weakness, is it getting better, or
No,
it's getting
doctor.
worse, or it just remain that way?
Doctor, it's like it's there since yesterday. It's that I'm not
Okay.
able to move it or feel, so it's
Mm,
just there.
okay. Is this only on that arm, or if have the same weakness in other parts of the body?
No, doctor, just in the my right arm.
Okay. Have you had similar weakness before in the past?
No, doctor.
Okay. All right. If I may ask, sorry, do you notice that do you know of anything that you do that make the arm weakness better or get worse?
No, doctor, it's not. It's there.
Okay. Is there any pain? Do you feel pain on the arm?
No, doctor.
Okay. Does weakness extend towards your hand or just on the arm?
Yes, doctor. Yes, doctor. My arm and my hand is involved. Yes.
Okay. All right. Do you have any slurring of speech?
No, doctor.
Okay. Any, drooling of saliva from your mouth?
No, doctor.
Okay. Any facial changes? You notice that your face has changed a little bit?
No, doctor.
Okay. And if I may ask, sorry, do you have you had any similar condition like this in the past? You said no, right?
No, doctor. I didn't have
Okay.
any form of weakness
Okay.
before this.
Okay. Any family history that's of similar condition?
No, doctor. But my mother has diabetes.
Diabetes. Okay. So sorry to hear. How is she feeling now?
She's. Thank you, doctor. She's good.
Okay. What's of your dad?
No any medical conditions or health problems with him.
Okay. I want to ask you,
Mm,
a little bit of yes and no question, if you don't mind. Okay. Do you have any headache?
no, doctor.
Okay. Any feeling of confusion?
Confusion? No, doctor.
Any blurring of vision?
No, doctor.
Any seizure?
No, doctor.
Any loss of consciousness?
No, doctor.
Okay. Do you notice that you have difficulty in swallowing?
No, doctor.
Any loose stool or constipation?
No, doctor.
Any tummy swelling?
No,
Okay. Any tummy pain?
no, doctor.
Any pins and needle sensation in your hands and legs?
No, doctor.
Okay. Do you have any, you also notice any change in the color of your hands when you're exposed to cold? Sorry.
No, doctor.
Any joint pain?
No, doctor.
Any neck swelling?
No, doctor.
Any hot or cold intolerance?
No, doctor.
Any chest pain?
No, doctor.
Okay. Any feeling of your heart raising?
No, doctor.
Any body swelling?
No swelling in any part, doctor.
Okay. How is your any shortness of breath?
No, doctor.
How is your water works like? Any problem with your water work?
Doctor, waterworks is fine. Like as usual, I
Okay.
didn't notice any.
Okay. Do you have any history of high blood pressure or diabetes?
No, not in my information. Not.
Okay, all right. If I may ask, sorry, much kind of a personal question, if you don't mind. Do you smoke?
Yes, doctor.
Okay, for how long have you been smoking? And how many sticks have you been smoking per day?
Doctor, like 6 to 7 per day for last 10 years.
Last 10 years. Okay, I think you may need to
Mm.
stop cigarette smoking because it may also be contributing to what you're having now. And if you don't mind, can I refer you to our smoking cessation clinic after now?
Okay, doctor. Thank you.
Okay, do you consume alcohol?
Doctor, occasionally, just occasionally.
Okay, is it like do you binge? When you take occasionally, do you binge drink?
No. Just doctor,
Oh,
just on weekends,
okay,
occasionally in social limits.
okay. Are you on any medication?
No, doctor.
Are you on any party drug or some drug, some party drugs or some drugs you take as a, for pleasure?
No, doctor.
Okay. And if I may ask, sorry, has this condition, has it affected your family, your daily life in terms of your family life and your job?
Doctor, I am a taxi driver.
Okay.
So, it's in my right arm. So, like, I'm not able to do anything for last 24 hours. I'm like, oh, so I'm pretty worried that how this has happened and how will it recover. So, I'm not able to go to my work today as well. So, it has affected me.
Yeah, I can understand. But if I want to really advise you here, you may need to stop driving now and inform the DVLA because until you gradually tell you what you really have and subsequently we can advise you further what you need to do. Is that okay?
Okay, doctor.
Okay. What of you? Are you married?
Yes, doctor.
Okay. How is it? Are your family? Do you have children?
Yes, doctor. I have a kid.
Okay. Is your husband support? Is your spouse supportive?
Yes, doctor. Yes.
Okay. All right. Um. Okay. If you don't mind, do you notice any maybe increase in weight? Any weight gain?
Uh, no, doctor. My weight is quite usual.
Okay, no weight loss either. Okay. Do you mind if I examine you?
Yes, please, doctor.
All right. Please, okay. I want to first of all do a quick general examination on you. Okay, look at your hands, check and see the hands, check any clubbing, check for any, changes, xanthoma, in any tendon, xanthoma, check for any discoloration of the hands, check for the pulse. How is the
Oh,
pulse like? Pulse is
okay.
regular.
Pulses are regular. When you see the hands, they're only nicotine stain, and in the right arm, when you see that it's a little like flexed, there is a little posturing because of the weakness.
Oh, okay. Flex. Okay. Okay. And then, sorry if I'm asking, do you have any trauma to that hand? Probably, do you have any trauma to your back or to the
No,
hand?
doctor.
Okay.
No,
All right.
doctor.
So I look at the end, go to the head, then can I see your hand, please? Then can you raise up your two hand up? Let me see.
Okay, you are seeing both hands, and the right arm has a little posturing.
That's more like a pronator drift, right?
Yes, pronator drift patient is unable to do because the power is 0/5 in the right arm.
So yours is 0/5, right?
Yeah, in the right arm,
Z-
it's
Zero over
zero by
five.
five. Yeah,
Okay.
he's not able to like follow your commands.
Okay. Okay. All right. Then I want to look at the I want to put it down. I want to check the bulk, check the any articulation, any
Normal,
wasting of the hands, any wasting.
negative, no wasting.
Okay. Okay. Then look at the tone. How is the tone like? Is it hypotonia or hypertonia?
There's hypertonia. Tone is increased.
Hypertonia. Okay. Then the power is zero. Tone is increased. Okay. Check for reflexes on both sides.
Reflexes are exaggerated in the right side. There is hyperreflexia.
Oh, okay. Then I want to check for the. After I'm done, can you please? I want to check for the cerebellum. Can you please? Okay, you can't raise your hand up, right? Right. Okay, you can't do that. Okay. Then
Yeah,
I'll try to do.
unable to do the coordination.
Okay. 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 Even the finger notes, you can't do that. But in the other hand, it's possible in the other hand. It's normal in the other hand, right? Okay.
Sorry?
Then the other hand, the right hand, it is normal.
Yeah,
Cerebellum is normal.
left hand.
Yeah,
Left hand is like
it's normal.
it's normal. Left hand,
Okay.
then yes,
Then
it's
I
normal.
do the leg. What of the leg? Anything in the leg? The
So
same thing
you
in the
are
leg?
checking the power in both legs, and the power
Yeah,
is
in both, yeah,
intact.
yeah,
Yeah,
both
it's
leg is
intact,
intact too.
intact.
Okay. Then I want to do this sensation now. I did the sensation too with pinprick, cotton wood, anything. Is it intact?
Yeah, in the legs.
In the hands and leg sensation.
So sensations you are doing in the right hand, and there are some disturbance. There is some loss in the sensations.
Okay, both to pinprick and to cotton wood, right? Both loss.
Yes,
To
both, and there is some disturbance, but in the right hand only, not in the left.
Okay, then what of proprioception and vibration?
There is also a loss of in the proprioception in the form of vibration and joint position. It's also seems to be reduced.
Okay, all right. Then okay, I want to after I'm done. Can you work for me?
Oh, yeah,
Why is
patient is
the
walking
gate
for
like?
you.
That is
Gait
the
is
gate.
normal.
Gate is
Yeah,
normal.
he's normal. Normal walking towards you.
Oh, okay, then I want to look at the eyes and check the eyes and check for look at the eyes and check any. First of all, ask, do you have any problem with your smell?
No, doctor.
Okay, check the eyes. Anything in the eyes in terms of the visual acuity,
Visual acuity.
the
Your Yeah, visual acuity normal.
okay, the confrontational test, is it normal?
Sorry, visual fields you are asking?
Yeah, visual field. Yeah, visual field.
Yeah, visual field and visual acuity normal
Okay,
in
what are the
both
facial
eyes.
deviation? The facial deviation and the H sign, ophthalmoplegia, anything ophthalmoplegia?
Negative, and there is no facial deviation.
Okay, thank you very much. Do you have any concern?
So, doctor, what is happening, and is it treatable?
And that's a good question, actually. Actually, looking at what you had and the for the past 24 hours, most likely, and you have a issue of cigarette smoking.
2 minutes left.
Most likely, I think you're having what we call a stroke. Yeah, most likely you're having what you call a stroke, and in this case, and typically, that is one of the things I'm thinking. And also, it could still be that you could be asking you could still be having what look like a stroke, call it the stroke mimic. But we need to do some investigation, do a CT scan, MRI, and then do some other tests, ECG, do some imaging tests, sorry, on your brain, and then a picture test too, and then do a chest X-ray, and then a reading of your heart. They're able to determine what you have, and subsequently we need to um, involve the multidisciplinary team, which involve the nerve doctor and other specialist doctor to look in your case, and probably can offer you some support and then some follow-up subsequently. Is that okay? Do you have any other
Okay, doctor.
concern?
Thank you.
Do you have any other
No,
concern?
doctor.
All
No,
right.
doctor.
All right. Thank you so much. Thank you. I'll need to run some blood tests for you now, and then send
Hmm.
in some sample, and then send it to the lab for a brain test, a brain imaging test. Then after that, we'll be able to. I'll discuss with you the outcome, and then subsequently how we'll go further from there. Is that okay?
Yes, doctor.
Okay. Thank you. Do you have? It's okay. Thank you very much. Thank you.
Okay.
Okay, 15 seconds. You want to add special question in the history?
And do you have any headache?
No,
I think I
doctor.
asked that. Okay. Then that thing I did ask again.
Okay,
Okay. Okay.
time is up. Questions?
Okay.
So,
All right.
what are the differential you would like to keep in the case, please?
Yeah, the
Presentation, then
differential.
differential. Presentation, then differential.
Yes, please.
Okay, I've seen this 47-year-old Mr. Jack, who presented on account of 1 day history of inability to move the right arm. There's which said to be sudden in onset while he was watching television that fateful day. However, there's no history of blurring of vision. There's no there's no issue of blurring of vision or weakness in any other part of the body. There's no headache, no neck pain, no neck stiffness. No headache. However, he has no history of hypertension and diabetes, and he smoked for six sticks of cigarette for over 10 years, and with no family history. The mother is diabetic. However, the father is no family history of similar condition, and on other issue was not remarkable. On examination findings, there's there's is not any obvious cardiorespiratory distress. I noticed there was hypotonia hyporeflexia, hypertonia hyperreflexia with power of 0/5 in the right upper limb, with sensory affectation. However, cerebellum and so could not be ascertained, and gait is intact. Looking at my history and examination, most likely I think that my patient has a stroke, most likely a lacunar stroke, which is a mixed motor-sensory lacunar stroke as a differential diagnosis. Other differential diagnosis could be a stroke mimic, which could be either from it could be most likely a space occupying intracranial space occupying lesion can be differential, and also want to consider I think these are my two differential diagnoses I want to consider in this case, basically.
Okay. How will you like to investigate and manage this patient?
My investigation on this patient will, first of all, I want to do I will start by offering brain CT scan for my patients to rule out hemorrhagic stroke, and then subsequently do a brain MRI and with a contrast CT with brain MRI with digital with diffuse weighted imaging DWI, and subsequently I want to do a blood test, full blood count differentials, liver function test, kidney function test. I want to do bedside ECG, and to ECG, chest X-ray, echocardiography to rule out cardioembolic stroke, and also I want to do autoimmune markers such as ANA and other autoimmune factors that may be seen in this patient. Then also, as I think basically then clotting profile too, and then fasting lipid profile in this patient. These are my investigation I want to offer for my patient, basically. Then carotid Doppler too.
And how will you like to manage?
Yeah, management of this patient will involve a multidisciplinary approach, which will involve the cardiologist, the neurologist, the neurologist, the radiologist, the specialized nurse, the physiotherapy, occupational therapy, and also vis-a-vis the cardiology, if there's any involvement of the heart. And then also I want to counsel my patients of the likely disease condition, and then follow up the plan of my management, and if after management to further clinic follow up and serial monitoring of proper clinic follow up. And the part of the acute management, I want to admit my patient in the stroke unit. To perform after the CT scan and MRI is out. This is more than 4.5 hours. I want to start commencing. If there's no evidence of hemorrhagic stroke, I want to commence my patient on aspirin 200 milligram daily for 2 weeks, then convert to clopidogrel, and then start him on statin, and also advice on smoking cessation, and because also advice on smoking cessation, and also then driving for him to stop driving, and also he may also benefit from other management like if the BP is elevated, following blood pressure, if it's elevated, I may need to control the blood pressure, and then basically if there's evidence of need for us, if there's evidence of cardioembolic stroke, if need be, I will treat that as such. Thank you very much.
Thank you.
Okay, time is up, 5 minutes exactly. But I will ask him one more question. Dr.
Yes.
Henry, do you think with the smoking of 6 cigarettes per day, is it a factor to have a stroke? Would you consider
Um,
him as a heavy smoker?
no, 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 no.
Okay, so let's have another differential. If you don't suspect this is a stroke and ischemic one, what do you think? Definitely he's
Um,
not hemorrhagic because no blood pressure or no hypertension, right?
yes.
So what do you think the
Yes,
other
sir, blood
cause?
pressure is fine.
Fine. So it's maybe it's one of the it's a differential stroke. You mean spastic monoparesis, right? What else can be the reason or the differential of spastic monoparesis?
The vasculitis.
Okay, good.
It could be, yeah.
And you will have
Um,
also history of vasculitis, like rash or muscle pain.
yes. Mm.
What do you think in young patient might have upper motor neuron lesion?
If he has basically has it could be hemiplegic migraine, it could be thought palsy, it could be so many.
Monoparesis.
Okay,
It's not.
monoparesis. It could be diabetes can be a cause of monoparesis. Um, then other cause of monoparesis could be um, okay,
Okay. What else? Give me more differential. In a neuro station, if you
I
have
would have considered I would have considered multiple sclerosis, but it doesn't. There's no. It doesn't
yes,
fulfill the criteria. It doesn't fulfill it. There's no other
neurological
not
manifestation, you
not
mean?
here to suggest multiple sclerosis. Yes, so that's why I didn't consider it in this patient.
Yeah, but still it's one of the differential, right?
Yeah, I might consider
Yeah.
it as probably the first attack,
Young
but
patient with the
mm,
hyperspastic or hypertonia,
mm.
hyperreflexia, upper motor neural features. Okay, that's enough. Dr. Minam will comment now. Then I will.
Yes, sir.
Yeah,
So,
you can comment. Yes, please.
yes, so sir, history was very good, and doctor has asked everything on the CNS. But I would like to just add one thing that I think that history of hospitalization or surgeries, I think he didn't ask the patient. So about the any past hospitalization or surgeries or any admissions in the past. So he had a history of hospitalization 1 year back. And if you have asked me, so I would tell you that I had some problem and I had admitted I had some blurring of vision 1 year back, for which I have been admitted and doctor gave me some medications. But after few days of admissions, I was quite fine and my vision became quite normal. So that was a clue for MS in this case.
Okay, what else he
That's it.
missed?
That's it. So.
Okay, so let's learn from the point. Okay, Dr. Henry?
Yeah, yeah,
Okay,
yeah,
even stroke. I heard you looking for xanthulathma, right? Xanthulathma. I hear that.
yeah, yeah,
So you are suspecting familiar condition
yeah.
with high or hyper coagulable state. So you have to screen for them. What are the hypercoagulable states you know and you should screen for?
Diabetes. Sorry, hypercarbohydrate state. Um, yeah, it could be hyperlipidemia,
Okay,
because
the
yeah,
familial one, yes.
familiar ones, yeah, hypercholesterol, familiar ones. Then
And it's negative. You don't have any family
yes,
history, right?
no.
So what else?
Other hypercoagulable state is
Okay, if you
things
have
like
a female, what you should ask? If you have a female,
a female.
yeah, in
You
the
mean
form of
female? APS, antiphospholipid syndrome.
perfect. So that you will ask about miscarriages and
Yeah, and
birth control pills.
birth control pills. Yeah.
Okay, I heard you asking about blurring of vision, right?
Yes, I ask if he has a short blowing of vision.
Yeah.
I ask.
Yeah, suppose also to be positive, and this is
Mm.
as a history, or you can add as a question now or before. See
Okay.
that? Yeah. So do you have,
Noted.
particular if you suspect MS, as in this scenario, particularly in young patient with unexplained neurological manifestation? So either you will search for the cause of hypercoagulable state, history-wise, or you will ask about the manifestation of multiple sclerosis. I heard you also asking about any previous attack, right? Of same
Yes.
same condition.
Mm.
Okay, so if you have a good surrogate, kind one, he might tell you about the past history, and you can get the clue. Maybe in this scenario, yeah. Also for the learning purpose, it's okay. Sometimes we make it difficult to try to catch it by difficulty, but we are learning. So whenever you have spastic limb, you have to rule out multiple sclerosis, particularly those in young patient or young age, particularly the female. So the female are more, right, susceptible to
Yeah.
have the multiple sclerosis. I think 9 to 1 or the SLE 9 to 1. Which one is 9 to 1? SLE or the MS?
Which one is what?
The percentage 9 to 1. Female to male.
Okay, it's SLE.
SLE, okay.
Mm.
Yeah, it's SLE, not MS. But
Mm.
still, the autoimmune more in the prone, the family, the females are more prone to have the autoimmune condition. And multiple sclerosis,
Yes.
one of them. Okay, as a differential again, put it as one of your differential, not only in this station as a long, even in the neurological station with the with the short station of neuro. If you have spastic limb or even spastic paraparesis, multiple sclerosis one of the commonest differential ever. You
Mm.
have to mention them along with, as you mentioned, the space occupying region, stroke, either hemorrhagic or infarction or ischemic one. If you have, for example, monoparesis or hemiplegia.
Mm.
But for the paraparesis and monoparesis, multiple sclerosis could be the top,
Okay.
right? Okay. So I will ask you now in this topic, how to investigate multiple sclerosis.
In investigation multiple sclerosis, I'll start by doing a brain CT and MRI, in which I want to see the downward fingers in the paraventricular region areas of the brain. Also, maybe in the cerebellum, it may be in the brainstem. It may also be in the cortex. Definitely. Then also want to do lumbar puncture to check for cerebrospinal oligoclonal band. Then I want to do visual evoke potential and vis-a-vis blood count to check for the aquaporins and to rule out and to check for antibodies in the blood. And basically I also do baseline urine and kidney function test, kidney function test, lipid profile, full blood count differentials, and liver function test. I think these are the things I want to do for this patient.
Okay, these are as general investigation, right? But
Yes.
specific, you mentioned earlier the MRI, brain and spine,
Mm.
looking for the myelination, and you can apply McDonald criteria. What
Yes.
if you have the case again as you suspect it as multiple sclerosis? What test you have to do? Adding
Lumbar
to
puncture.
no, not
Okay,
test. I mean examination, not test.
okay,
Examination.
examination. I want to look at to check for internuclear ophthalmoplegia in the eyes to check for
Perfect.
the
Yeah, how to do it?
Yes, usually I will take his consent and tell him to look at my hands while I check for the H sign from left to toe, from left to right, and then see if there's any inability for the left the eye that is involved to abduct. Then the nystagmus on the other eye that is not on the eye that is on the side that is not affected will have nystagmus. While the part that's affected, there will be inability for the eye to adduct, basically.
Perfect. So one of the eyes will not be
Mm,
able to adduct, and
mm,
the other will have nystagmus. This is for the affected side.
yes.
Could be both sides to be
Yeah, it could
affected,
be both
and you
sides.
will have
Yes.
both of them. So the failure of adduction of both eyes, along with the nystagmus in both eyes. And this is affecting what? What we call?
The MLF, the
Yeah,
medial,
MLF, medial,
yeah,
um,
what do you call it again?
longitudinal,
Fasciculi.
medial, longitudinal,
Yeah,
fasciculus.
fasciculus, yeah.
Okay. What the other examination in the eye you have to do?
In eye, I want to check for also the RAPD for then the fundoscopy too for optic to check if there's any to check for optic atrophy.
Yeah.
The fundoscopy to check for optic atrophy.
Okay, perfect. What else? As a pupil?
Then as a what?
Pupil, pupil.
Yeah, okay, yes, I want to do reactive afferent pupillary defect, RAPD.
Yeah.
Yeah.
RAPD, yes.
Mm.
How to do?
Yes, usually I will look at I will push a pen touch in the left eye first of all, check for direct, and then look at the consensual, then go for the other eye, do for direct, and then the consensual, then do for swing test, then the swing
Yeah.
test. Then now, yeah, basically.
So direct and indirect light exposure. You will put the light on one eye, then you will swing to the other, back to
Mm.
the left, and you will see if it will be positive, what will happen. For example, the
If it
left is affected, optic nerve or optic neurites in the left side. What you will have?
Yeah, in the left side, if it's affected, it will, once I put the touchlight there, the pen touch, it will not be able to. Ideally, it should constrict with light,
Exactly.
but there'll be failure to constrict with light because of the afferent issues there. And then, then if I should use the other eye that is good, there'll be constriction. Then the consensual reflex, the swing, there'll be also constriction in the other eyes. So you see constriction in the good eye, and also constriction in the bad eye because of the
Okay.
efferent is still okay.
Okay.
Then, but the other ones, the bad eye, once I put the pen touch there, it will still not dilate. Even do the conceptual too, it will not dilate because there's problem with the afferent.
No, it will dilate.
It seems as if it's dilate because it's resuming from constriction. So it's going back to the normal size. So it appears as if it's dilating, but it's going back
Yeah.
from the previous constriction to the normal eye, basically.
Yeah. So it's an appropriate reaction to the light whenever you do the second eye examination or the diseased eye examination, right?
Yes, sir.
Supposed to be constricted earlier initially, then later on it will dilate as inappropriate reflex, which is called ra- ra- rapid
Rapid. Sorry, I didn't get rapid. Z
afferent pupillary defect.
defect. Okay, yeah.
So what the defect? The pupil, instead of being constricted, it will dilate.
Yeah.
Okay, but initially it would be constricted.
Yes, sir.
Okay, thank you, Dr. Inari. Well done. Take care of the multiple sclerosis as a neuro station and also as a lung. It's very common topic.
Yes, it is.
Okay,
It
let's
is.
continue the management. How to manage the multiple sclerosis?
Okay, management will involve a multidisciplinary approach, which will involve
Perfect.
the neurology that specializes in most in similar condition, also
Okay.
the radiologists that will do perform the imaging test, the physiotherapists, the specialized nurse, the psychologist that will also counsel in case of any depression, specialized psychologist, also the occupational therapy, and then social services that may help in helping in one way or the other in daily activities at home. Then also as part of the acute management, in this case, since the patient will benefit from steroid from the acute methylprednisolone, maybe giving 500 milligrams to 1 gram daily for 3 days, and then subsequently may start to consider some disease modifying agents such as such as not and so such as
Okay,
gatremia
natalizumab,
and natalizumab,
natalizumab,
yeah,
yes,
natalizumab, gatremia, and the rest of them, and then
fingolimod,
yeah,
yeah,
fingolimod. All these are things I may want to consider as a disease modifying drugs. But at the acute form, I'll start with steroid first of all. And
Perfect.
also
Yeah.
ophthalmology too. The ophthalmologist will also be part of the team that also manage him for the visual issues,
Yeah. Perfect.
basically.
If you cannot remember the names, just give example of, as you said, disease modifying agent of multiple sclerosis, the MAMS. Okay. If he asks you, give me example, you can say there is IV, there is subcutaneous, like interferon, and there is also oral, like fingolimod. Okay.
Yes, sir.
Yeah. Thank you. Yes, Dr. Nada asked one more question. What are the good and bad prognostic factors in multiple sclerosis?
The good prognosis and the relapsing remitting is a good prognosis. Then if it's female, good prognosis. Male is bad prognosis. Young person is good prognosis. Elderly patient is bad prognosis. And then yeah, I think basically these are the ones I can remember. Basically,
Yeah, the typical presentation, like
yeah,
motor presentation, is one of the good prognosis.
good prognosis. Yeah,
Always remember the typical presentation of any disease is good prognosis. Atypical presentation is bad prognosis. The female is good prognosis because they are common. The less common is the man and or the males, and they are poor prognostic. The young, of course, as you mentioned, and the type relapsing, remitting, and it's good prognostic. And the worst is secondary progressive, for example. And the third type is
yeah, primary progressive
primary progressive, secondary progressive, and
and
relapsing remitting, the most common one.
okay.
Yes, that's this
Yeah,
the prognostic factor.
that's
Anyone
good.
want to add any question to this point? Any suggestion? Any comment? Thank you, Dr. Henry. Well done.
Thank you, sir.
You did
Thank you.
great. Take care of the past medical history. It's not only medical
Yes,
history. Past history or past medical means surgical, drugs or medication list, or hospital admission, surgery, allergy, over-counter medication. Okay?
yes, sir.
Yeah.
Thank you.
Put it in your list as approach.
Yes, thank you.
Okay. Thank you, Dr. Henry. Anyone want to comment or add a question?
Dr. Basil, please can you
Yes.
repeat the relative afferent pupillary defect? بس
Okay.
explain
Relative
it بس brief.
afferent pupillary defects. It's simply you will expose both pupils to the light. Okay. Direct and indirect. Suppose the direct one, first moment, the eye or the pupil will constrict. When you do the first, for example, let's assume the left eye is diseased. So you will put the light directly to the left eye first. Then you will go swinging the light to the left, to the right. Okay. The right also will constrict. When you go back to the left eye, which is diseased or having the afferent defect, you will see the eye is dilated instead of being constricted. Okay, clear? Simply, if you don't understand it and you want to say to the examiner, just tell him it's the direct and indirect light exposure reflects or the pupil reflects to the light. Direct and indirect by swinging the light between both pupils. But as I said, you will start with the left. Let's assume the right. We started from the right and the right is intact. The constriction will happen. Then you will swing to the left. Okay? Still the left is constricted as direct. But when you swing back to the right, the constriction is still there. Why? Because it's intact. But when you go to the left, you will start exposure to the left first, and you will go to the right. The pupils will constrict. When you go back to the left will dilate instead of constriction. So it's a matter of indirect. When you go to the intact eye, the left eye or the diseased eye will be dilated instead of constriction. Okay, clear?
Clear, thank you.
Okay, thank you. Anyone else? Any questions? Anyone want to comment? Multiple sclerosis is very important topic. You have to know the investigation, the management, the approach, the history taking, and how to diagnose, and the types as well. Okay, anyone want to add any question before ending the session? If no more, we can end the session. Thank you, everyone. Thank you, Dr. Henry, Dr. Minam. See you tomorrow, inshallah, the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.